Hello everyone, welcome to the 11th episode of Spotters and Boosters, and this episode is based on clinical care. The homework for the previous session was number 1, what is the composition of Malarday? It contains norgestil, levonorgestil. Norgestil 0.30 milligram or levonorgestrel 0.15 milligram plus ethinyl estradiol 30 micrograms 21 tablets and 7 tablets of fumarate 60 to 75 milligram. Why is this ethinyl estradiol the estrogen of choice in the combined oral pill? The ethinyl substitution of carbon 17 position of the estradiol increases oral potency because it reduces inactivation by inhibition first pass hepatic metabolism. It is cleared slowly than estradiol due to slow hepatic metabolism. Mestranol is another oral estrogen used in oral contraceptive pill, but it is also converted into ethinyl estradiol. Question 3. Prescribe an oral contraceptive for a female of 35 years of age. Here age is important. If required, a progesterone-only pill should be given, for example, linaclotide, continuously to avoid the risk of endometrial hyperplasia, as with the use of ethinyl estrogen. Question 4. Indication of higher dose of ethinyl estradiol. Usual dose is 30 micrograms, but higher dose may be required under certain conditions: obesity, rifampicin, use of topiramate or ritonavir. These are the 3 drugs that induce the metabolism, so reduce the contraceptive action. Or the best thing is use alternative method of contraception instead of a pill. Question 5. Which oral contraceptive pill is preferred for women with acne? Here androgenic effect is already there. Therefore, drugs progesterone without androgenic action would be needed. For example, desogestrel or norgestimate, and such combinations with ethinyl estradiol. Next question is, which statin is drug of choice in renal disease? Compared to rosuvastatin, atorvastatin does not require dose adjustment because less than 2% is excreted by kidney. Now, statin, as a corollary, I may tell you, statins have renoprotective action also. Question 7 is, any lipid lowering drug reduces lipoprotein A. Niacin or nicotinic acid is the only lipid lowering drug that reduces lipoprotein A. Question 8, any other drug that also lowers lipoprotein A? Not many. Tamoxifen is one drug, that is SERM, that is has reduction, that has shown reduction in the lipoprotein A level, although it is not used therapeutically for that purpose. Question 9. A drug that inhibits cholesterol biosynthesis by acting a step earlier to the step statin site. Answer is bempedoic acid. Question 10. An oral lipid lowering drug that inhibits formation of VLDL in hepatocytes. Actually, this is the main mechanism of action of lomitapide that inhibits microsomal triglyceride transfer protein needed for transfer of triglycerides into lipoproteins in the hepatocytes. And therefore, this is a new drug, and it has been promoted for the treatment of homozygous familial hypercholesterolemia, where many drugs have attenuated response. Particularly, statin will show only diminutive response. In this condition, it has been promoted. Now, let us start this section. Clinical case 1. A 17-year-old male was admitted in an unconscious state in emergency room. He had generalized convulsions once. He had no previous history of fits and was taking olanzapine 5 mg. On examination, 100 pulse, pupils normal, BP normal, respiratory rate normal, bladder not full. The plasma sugar was 48 mg and C-peptide levels were well elevated. His mother was on insulin and oral antidiabetic glabin-clamide tablets. 100 ml of 50% glucose was given IV, but even after 6 hours, sugar remained low. No abnormal muscle movements were observed. Mother confided that he often left his medicines in her medicine box. So what could be the cause of hypoglycemia? What what is C-peptide? Why is C-peptide elevated? Why is hypo? These are all pharmacology related questions. Why is hypoglycemia prolonged? Can you suggest any other drug to treat hypoglycemia apart from IV glucose? It is not effective. What other measures will you take for rapid recovery? And is olanzapine overdose responsible for these conditions? They are the cogent questions. Come on. Now let us see the solution. Question 1 and 3. He could have taken several tablets of glibenclamide, which his mother was taking for diabetes, because mother gave history of mixing his medicines with those of hers, and he has some psychiatric problem for which olanzapine he was taking. The prolonged hypoglycemia is usually due to excess of longer-acting sulfonylureas, and one of them is glibenclamide. So there is a possibility of overuse, over toxicity. Question 2 is C-peptide is co-secreted with insulin by beta cells. Sulfonylureas are insulin secretagogues, so they also raise C-peptide levels. That further proves that endogenous insulin secretion was increased by some drug. Question 4. IV glucose is usually not sufficient because of prolonged hypoglycemia, and other drugs are needed, and one of the drugs is glucagon 1 milligram given intramuscularly, and if it is not sufficient, then other drug is octreotide 50 microgram to be given intramuscularly every 6 hours for 24 hours with continuous glucose monitoring and IV glucose. Prolonged unconsciousness could also be due to cerebral edema once hypoglycemia has improved, and he may require IV mannitol also. Question 6. Now the question is, olanzapine is a typical antipsychotic with a longer half-life, and toxic doses show drowsiness, coma, but anticholinergic actions, dry mouth, tachycardia, urinary hesitancy, or bladder should be full. Abnormal muscle movements are often seen and blood pressure is reduced. Paradoxically, pupils are constricted. It may cause hyperglycemia, and none of the key symptoms are present in this case. So it is perhaps not due to clinical case 2. A diabetic female 50 years taking metformin and glibenclamide had poor diabetic control, and doctor added third drug. Her fasting and post-glucose load plasma sugar became normal after about a week of addition of a third drug. However, she noticed frequency of urination and burning during urination. Now these symptoms have appeared perhaps after the use of third drug. Routine urine microscopic examination showed presence of pus cells that shows that she has developed urinary tract infection. Now the question related to pharmacology are, what is the reason of polyuria and burning urination? Could it be related to the third drug? So if it is related, what is the nature of third drug? Why has the third drug caused these symptoms? What are the additional benefits of such drug? And if a change is needed, what other drug you would like to add in place of this? Solution is, addition of a third drug has resulted in adequate control of type 2 diabetes mellitus, but it has produced some unwanted effects. She has developed polyuria and urinary tract infection, possibly causally related to third drug, and such a drug could be SGLT2 inhibitors, dapagliflozin, empagliflozin, or others. Now, SGLT2 inhibitors act mainly by excretion more of the glucose, so there is a osmotic diuresis, and increased glucose concentration in the urine predisposes to infection. And these infections are genital and fungal urinary tract infections. Now, these drugs increasingly used as anti-diabetic drug today because of the beneficial cardiovascular actions. Empagliflozin, dapagliflozin have been shown to reduce cardiovascular mortality and heart failure hospitalization, worsening of heart failure in patients with heart failure with reduced ejection fraction, and even with heart failure with preserved ejection fraction. They also slow progression of diabetic renal disease. Therefore, they are more used. Now, however, because of the symptom adverse effects, if a change is needed, incretin mimetic drugs can be given. For example, GLP-1 agonist, semaglutide, or any other. But semaglutide has been made available orally, so it can be used in place of SGLT2 inhibitor. The other drug is DPP-4, teneligliptin, or any other gliptin could be used. But SGLT2 inhibitors have beneficial effects on cardiovascular. Now, the female student, a hostler of 20 years had low-grade fever, had headache and malaise. She had lost appetite and developed nausea. The temperature record of last 5 days revealed intermittent pyrexia. She took paracetamol and domperidone for symptom control. Vomiting subsided, but fever continued. On examination, the heart rate was 66 per minute, blood pressure was 100/70, respiratory rate was 18 per minute, and mild abdominal tenderness, just palpable spleen, but no other signs of localized infection. She was advised for blood test on 9th day of fever. The complete blood count showed leukopenia, slightly lower normal, with little lymphocytosis, otherwise normal. Typhoid antibody and titer and Vidal agglutination tests were positive. Now prescribe oral therapy for this patient. It appears to be a typhoid fever or enteric fever. If oral therapy fails, then which parenteral drug would you prescribe? Which drug can prevent carrier state? And educate patient for completing the course and role of hygiene and prevention of. Now, this patient will require ciprofloxacin orally, but today ceftriaxone is the first choice, which is initially given parenterally. Ciprofloxacin can also be given parenterally, but ceftriaxone is preferred. In place of ceftriaxone, depending on the level of prevalent resistance, cefoperazone, cefotaxime can be given, and azithromycin 1 gram once daily, then 500 milligram orally for 7 days is also found to be effective, alone or along with above drugs. If ceftriaxone resistance is there and third generation cephalosporins are not showing response, then meropenem is the drug which can be given if there is a toxemia or shock. Then dexamethasone is invariably needed for critically ill patients. Alternative, less effective drugs are amoxicillin, cotrimoxazole, or chloramphenicol as a last resort because blood is a main problem. Treatment. Prevention of carrier state is very important, and for that, ciprofloxacin is given for 4 weeks. It eradicates carrier state. In a similar note, amoxicillin, ampicillin, or cotrimoxazole are alternative drugs. Cholecystectomy has been advised to prevent recurrence in carrier, and vaccination is available oral and intramuscular. Oral is given as multiple doses, and intramuscular is given single doses repeated 3 years thereafter. Immunization of household should be done, and education is required for technique of proper hand washing, particularly after defecation. Ablution should be done nicely, and importance of the nail trimming should be explained to the patient. We know the famous typhoid Mary case. Clinical case 5. An adult male 30 years of age presented with focal motor seizures affecting left arm and face. He ate non-vegetarian diet regularly. There was a past history of passage of white banded segments in the stool. CT-MRI showed nodular vesicular lesions in the right frontal cortex and some vesicular lesions in the brain stem near fourth ventricle. The peripheral blood showed eosinophilia. Neurologist diagnosis is neurocystic sclerosis after confirmation on CT-MRI. Now the question is, enumerate two cysticidal drugs effective in this case. Which one would you prefer as first choice and give reasons? And what other medications are needed immediately? The solution is, when there are active cysts with living larvae that can be seen on MRI, actually CT MRI, and there is no calcification, and cysts are in the colloidal state, that is larvae are degenerating, and these such cysts are seen as edema around the lesions in the MRI. These are treated with cysticidal therapy. Two cysticidal drugs are albendazole and praziquantel. Now, these two are effective, but when we compare, we will find these comparisons would be absorption of albendazole is inconsistent, but high-fat meal will increase absorption by 5 times. Praziquantel is absorbed very well, and the absorption may increase somewhat with food. Distribution is widely distributed, both drugs. Metabolism, there is a difference. Albendazole is metabolized in intestine and liver by cytochrome 3A4. It may induce its own metabolism, but it forms active sulfoxide derivative, which has much longer half-life than albendazole. And this active metabolite may also cross the blood-brain barrier and has cysticidal activity. Whereas praziquantel is actively metabolized to inactive products through cytochrome system. Parental drug enters, not the active drug metabolite. Concurrent dexamethasone use is invariably required and to reduce the inflammatory reaction of the dying larvae, and when it is used, dexamethasone increases bioavailability of albendazole sulfoxide, whereas it reduces bioavailability of praziquantel. There could be a mutual interaction between praziquantel and albendazole. That is, praziquantel increases plasma level albendazole sulfoxide. Therefore, these two can also be. Now, duration of therapy is usually shorter with albendazole compared to praziquantel. The cure rate is a little higher with albendazole, and cost is much lower as compared to praziquantel, so it is more cost effective. Adverse drug reactions are more or less comparable, and contraindications are also same. So, looking to these comparisons, even then albendazole is preferred in neurocysticercosis because it has more efficacy. One, second, it is safer, that is both are equal, and third, it is cost effective. Unit cost is less, duration is less, so total cost is less, and frequency of administration is usually once or twice daily as compared to praziquantel, which is usually given in 3 divided doses. Dexamethasone co-administration will increase the albendazole sulfoxide formation, so it adds to its efficacy and reduces inflammation due to dying worms. Praziquantel will not show this action, and the final point is it can be given high-fat diet to enhance the bioavailability. Looking to these points, albendazole is a preferred. Other medicines may be required. Glucocorticoids I already talked of. Anti-epileptic drugs, phenytoin or carbamazine may be given, but one should remember they are enzyme inducers. Intestinal tinea soluble infection is treated with single dose of praziquantel or niclosamide. And prevention is also needed: meat hygiene, adequate cooking of pork meat, avoidance of ingestion of fecally derived eggs by means of good personal hygiene, effective fecal disposal, and treatment and prevention of intestinal infections. These are points which make effective. Now, notable points about albendazole is if it is poorly absorbed orally, it is better. It kills intestinal worms. But If we give it fat meal, it will be better bioavailable. Its metabolite also, so it is better for neurostressor. Now, albendazole is usually given as single doses for luminal roundworm infestations, and yearly dose of mass treatment is also recommended. National Deworming Day is celebrated on 10th February and 11th August every year. Here, albendazole is given to children above 2 years of age, including adults. Tapeworms, trichinosis, strongyloids, albendazole dose is higher, and as I told you earlier, a longer acting active metabolite is made by albendazole. Now, homework for this session is find out the basis of use of ceftriaxone as the first drug of choice in typhoid. Why is chloramphenicol not used in typhoid fever today? How does ciprofloxacin act in typhoid fever? Pharmacologically, segregate anti-diabetic drugs into two groups, those which are hypoglycemic and those which are euglycemic, and also enlist anti-diabetics that cause weight loss, weight gain, or are weight neutral. Also find out an antimalarial occasionally used intravenously that may cause profound hypoglycemia. An antihypertensive drug formerly used intravenously for rapid reduction of severe hypertension but causes hyperglycemia. Currently, it is indicated for the treatment of insulinoma. Why is praziquantel contraindicated in the treatment of ocular onchocerciasis? This last part of the homework is you have to find out the worm and that causes the disease and its drug of choice. So it is a good exercise for revision and preparing yourself for examinations. Find out from the standard book. You may also visit the next episode of SNB 12. Thank you.